Hello, everybody. Amanda is not with us today. We are going to do a podcast about our perioperative pain management. I'm Dr. Abbasi for Essence, and it's my great pleasure to have Dr. Praveen from India with us because as we will learn, pain is a very subjective thing. It has a very cultural background to it. So Dr. Praveen, introduce yourself to us. Who are you?
Good evening.
So
I'm Dr. Praveen Saxena. I'm an orthopedic surgeon who specializes into spine, and I practice in India, the western part of India to be precise, from the state called Gujarat. And I'm happy to be here with Dr. Abbasi, here to learn a lot of things from him.
My name is Alyssa Haber. I'm the PA here at Inspired Spine.
I'm Dominic, PA number 2.
Okay, well, most of the load of the pain management goes to you and to Tara, who is with us. But before we start, there's something that I learned in India. People call doctors by the first name, but doctor first name, like I'm Dr. Hamid in India. Is that correct?
That's correct.
How comes?
Yeah, we love to address people by the first names.
Yeah.
It kind of establishes a bond.
Yes.
And you get to open up.
That's why I call you Dr. Praveen.
Yeah.
And I would be called Dr. Hamid in India, which is interesting.
Yeah.
So now, before we start, I want to say that I was just saying, when I was a child, if I would fall down or injure myself, I would wish that my mother wouldn't see me, and I would hide it from my mother because she wouldn't come to me, oh, baby, what's going on? She would come to me, foreslap and backslap me a few times and tell me I should walk more carefully. So, and I think Dr. Praveen is as well shaking the head. So you see, there is a huge cultural aspect to pain, and pain is a signal. Pain, as a matter of fact, in our brain is like a sensory that when I touch you, the path goes all the way to your brain. There's pressure there. Pain is very similar, different receptors, but we learn to react to the pain. Like if you touch me, I not necessarily take my finger back. Maybe I do, but if for the pain, we develop this cultural, kind of reflexes and so on to prevent injury. Pain itself is not the injury. Pain is not the fire. Pain is the noise of the smoke alarm. Now, in some cultures, you see, oh, fire, let's go have party. But in some cultures, says fire, call the army, call the navy, call the fire, call the department, call the police department. And in the United States, pain is that. Call everybody because some injury is happening and people grow more pain sensitive. The advantage of that is that you have less injury, life expectancy goes higher. Like in my culture, it wasn't unusual when I grew up that every family lose a child. As a matter of fact, my family lost 2 children. That's so extraordinarily rare here. And part of it is that, we say, oh, helicopter mothers and helicopter family and so on. Yeah, but the advantage is you didn't lose 2 children, well, in a 9 children family. So,
That's still a lot.
yeah, but you see, there's advantage and disadvantage. But nevertheless, we are going to talk about the perioperative pain management in our culture for our patient because there are lots of specific things goes about that. And pain for a patient is always real. Now, I'm saying always because we give a benefit of doubt because there are patients, no matter where you are, that pretend to have pain to get some secondary gain. Now, what do we call that? If somebody pretend to have a symptom, but they don't have that symptom.
Effusions, mal, like that.
No.
Somatic.
Malingering.
Huh?
Yes.
Yeah, malingering.
Malingering. That the malingering is when patient knows they don't have a pain, but they tell you they have pain. Thank you for the help. But they pretend to have pain for some other reason, malingering. But if patient really believe they have pain, but physiologically, when they have no significant sign of pain, because pain is a signal, then we call that the different name. What do we call that? Psychosomatic.
Yeah.
Okay. So, and if somebody comes and just want to get a Percocet from you, is malingering. If somebody comes truly, they feel they have the pain, even though every test we do says there is no reason for you to have pain. But at the end of the day, how do we know really? Because we know once those paths in the brain develop and we understand them, like it's called so-called Labbe circuit, meaning that the pain signal goes from place to place to place to place, and then reinforce itself. And that once it reinforces itself, it's as much real as like if I cut your leg. Now, how do we know that? There is a so-called obsessive compulsive children who injure themselves. To solve that problem, that they literally put nails in themselves. In Galveston, my boss, Dr. Nata, was an expert on that. We would go put a needle electrode in part of the brain. We call that anterior cingulate gyrus. You poke a hole there with electricity to break that circuit. And we know those people who got that, they separate the emotional response of the pain to pain itself. Those patients, if you ask them, yeah, how bad is your pain? 10 out of 10, let's go have a coffee. So pain, a lot of pain is the emotional response to that. Another thing we know, if you don't treat the pain properly, it's more likely you develop those paths in your brain. This is a fact. So the worst thing you can do to a patient perioperatively, not to treat their pain properly. So what is the sweet spot? That's what we are going to talk about today. But before we start that, tell me your memorable experience you had in our practice with pain management. Is there anything come to your mind, Dominic or Alyssa?
Yeah,
Tell me.
actually,
Give us one of your stories. It's a podcast.
yeah, it was very a little while ago. She had a microdiscectomy. By most people's standards, is pretty fast to recover from surgery. But she immediately afterwards, 10 out of 10 pain, worse than any pain she had had beforehand, and it was just kind of, okay, well, what's going on here? What is this? And she had a seroma back there that was really compressing everything. So way worse than the discs ever did to her nerves. And even during the surgery, there was a very torturous nerve root, and that got manipulated to get it free. So she very clearly had some intense pain, but couldn't get it well controlled, and then from that point on, she just kind of kept spiraling.
And the lesson we learned from that is take every pain seriously. Every pain seriously. Now, I want to hear your story, then I will give you my story. Any story you remember?
I have a lot of stories. Most of my stories ultimately have a lot to do with the psychosomatic, as I'm a huge outlook person. A lot of my stories come when we go rounding. We do a lot of rounding in the mornings, very early mornings when people wake up and they're in a lot of pain. And you have to have those conversations about movement, as nobody wants to get up and move. And you have those connection between what you want and where you want to be and what you have to do to get there versus just taking the medications.
Yeah.
So that's my biggest
And
takeaway.
that the lesson I take from that is that we are not talking about pain as general management. We are talking about perioperative pain management. And one of the things that, they call it the fifth vital sign, pain. Somebody decided, give the patient a number between 0 and 10. Everybody's familiar with that. And then lots of people who don't have any experience, especially, unfortunately, lots of time in the hospital, young nurses, they take that number and make it based on that number. All the action is based on that. Like patient is sitting in the bed. What is your pain? Oh, my pain is 15. Ha ha ha. And then more medication, rather than, understanding pain is a physiological response. You cannot have pain 10 out of 10 and sitting there and shoveling jello. Because our body says if you have 10 pain out of 10, you're about to die. Or your body conserve all its activities and the resources for survival rather than eating jello and so on and so forth. So we have to as well put additional, I would say, expertise in that to understand when do we give pain medication? When do we not give pain medication? And that is something that still today, lots of people in the United States die of over-medication. Let me be very clear. I have never, not a single time, I have lost a patient to pain. But I have lost patient to over-medication. And in many of those cases, especially in experienced people, including doctors, nurses, residents, and so on, they dissociate other venues how you establish pain from just the number patient gives to them. And they act in rapid succession, and then all that medication hit the patient at once, they quit breathing, and they die. It happens all the time in 2025 in the United States, and I'm sure anywhere else, to a point that I want to bring your story. When I was in India, they don't give narcotic to post-operative fusion, which is unimaginable for me. But that is your practice, right?
Yeah, in more than 2 decades of spine practice, I don't recall even giving it once.
So what, do you even have narcotic in India?
Yeah, we do.
What do you give it for if not for spine surgery?
Well, maybe culturally, our patients can tolerate the pain much more than we think they can. And most of the times, narcotics are reserved for cancer patients to take care of those who are terminally ill and you can't take care of them. Post-operatively, I rarely recall. I don't even during my trainings, I don't remember.
Yeah, well, I can tell you, United States, you couldn't do surgery general, not only spine surgery, if people expect that I tell all my patients, number one, this is perioperative pain management. The first part of perioperative pain management is managing patients' expectation.
Oh, 100%.
Tell me about it. You 100%. How do we do that?
Let them know there will be pain afterwards. The goal isn't immediately after surgery, 0 out of 10 pain. You just go walk, pick daisies. It's, hey, it is going to be exquisitely painful. If we can get that down within the first week to 7 out of 10 or so for you, good. That's where we want it.
But we have like over 1,400 testimonials now. Many of those patients, they tell when they woke up, they noticed though some pain got better. Which pain is it?
So usually radicular pain gone in a flash.
Yeah.
And that's always a good trade, because the thing is, after surgery, it's pain with purpose. You're not having all of this senseless aching and agony. You know that it's going to get better. You know that you're doing this for something.
And surprisingly, they can say sometimes, often, that the pain is different.
That's the number one thing I hear, even doing post-op phone calls. Typically, we call the patient post-operatively between day 1 and day 3, ask them how they're doing. Number one question we ask is, how's the leg pain? How's the leg pain compared to the back pain? Almost always they either respond with, it's gone or it's different, meaning we open up that foramina, we release that nerve open. It's going to feel different. Either it had damage prior or we traded it for a little bit of a neuritis post-operatively, which again, we educate pretty heavily.
How do you educate the patient? Because this is a huge part of our perioperative pain management, post-operative neuritis, which we categorize in 2 different groups. We call nerve irritation if it doesn't have a severe weakness, but if it has severe weakness, meaning 3 of 5 of motor function and below, we call that neuropraxia versus nerve irritation. But what bothers the patient mostly is the pain itself. How do you educate our patient about that?
Well, the best way to educate patients is before they ever undergo the surgery whatsoever. We give them, typically we say about 8% per level is there.
In the learning curve is actually about 15%. And that include all the levels. Okay. And for 5S1 is the highest level. 5S1 has 3 to 3.5 times more risk of nerve irritation. That is like, if you have 5S1, it's more likely you are going to have that. Now, a lot of doctors and so on, they ask me, what does it correlate to? Now, it obviously, surprisingly, doesn't correlate to the size of the disc spacer cage we put in. It doesn't correlate to many factors that initially I thought it correlated to, but 5S1 is the main factor.
Mhm.
Number two, the factor is experience of the surgeon. If you have done in your learning curve, it's going to be higher than, and it actually correlates with the number of the passes. We looked into
Yeah.
that. If you pass more than 3 times below the facet, that risk is higher. And then another thing that you guys need to educate the patient is if patient had neuropathic pain before the surgery, meaning that nerve is already irritated, it doesn't take much to put it over the edge. Now, what is the best sign you know on the paper? You look at something, you read something, you say, oh, this patient has neuropathic pain or is prone to that. What is the sign? What am I looking for? There's a medication. If patient is on Neurontin, if somebody has been on Neurontin, somebody gave the Neurontin to this patient for a reason. Even if patient now nerves are cool right now, that they don't have neuropathic pain, but they are on Neurontin or have a history of being on Neurontin, that nerve, it's actually based on the studies that we are doing right now. I think that is 1.8 to 2%. 1.8 to 2 times higher rate of nerve irritation if they have been on Neurontin. Okay, there are some other factors that we are investigating, but if you see a patient is on Neurontin, talk to that patient more about expectation management and so on. So let's say a patient does have nerve irritation, which is an important part of nerve. We are still haven't started how we manage that. What do we say to those patients, Alyssa? What do we to patient that we about neuritis and so on? What do you tell them about
Are you talking before surgery or
before the
after?
surgery? I'm talking
Well, I'm a huge visual person, so I almost always will draw out how we perform the surgery and the left-sided approach, explain how the only way to get
Mhm.
into the disc space that we like to is by dilating the space, which
Mhm.
oftentimes involves moving the nerves out of their location to avoid any damage. Once you kind of explain the process of moving the nerve out of the way, and we say anytime you move a nerve, it can get irritated. Typically, they'll then correlate
Mhm.
what we did with their post-op
Mhm.
neuritis.
And
that's
then
how I go about it.
when it happens, is 9 out of 10 times is like a radicular pain.
Mhm.
Correct.
And 8 out of 10 times is L5. Where is L5?
Yes.
Where is L5?
I was just
Back
saying
of the
the same
thigh.
thing.
Yep.
Back of the thigh, down to the
Turn
calf.
around,
Yep.
going to the top of the foot, especially big toe.
Yep.
And that's
Right.
actually half the battle is if you know what surgery they're walking into, you can kind of show them what path each one could take if they
Mhm.
get it. And then when you talk to them afterwards, the biggest thing is they're scared. They
Yes.
think something went wrong in their surgery, but when they remember, oh no, Dominic showed me with his finger exactly where this is. They
And
go,
you just described 50% of our perioperative pain management, telling to the patient what to expect, and they shouldn't be scared about that. It is normal. And as well, we notice that the first month you see them is everywhere.
"Hmm,
You see them after 3 months is below the knee.
Yep.
You see them after 4 or 5 months is just top of the foot. And then after 9 months, it's just a big toe.
mhm."
Why is it like that?
It just takes some time.
How fast do the nerve heal?
Like 1 millimeter a month.
No,
Tiny, slowly.
They grow as fast as your hair in your head, about an inch a month.
An inch a month?
Yeah.
Wow. I
About
think this
the-
grows faster. I need a haircut.
That is how hair
An inch a
grows.
month? Okay.
So, and that is exactly, so you can imagine you need 9 months, 9
Mhm,
inch
yeah.
to go below the knee, and then the motor recovers faster because the motor that moves the toes up is not in the toe. It is in the calf,
Yeah.
right? So, but the sensory, and then I see a lot of these patients that they tell me, it doesn't really bother me anymore. But along when it's tried to heal, there is something that I hear again and again and again. Have you ever slept on your arm and the arm goes sleep?
Yep.
So what happens when you wake up? It's limp,
It's
completely limp.
tingling.
No,
and
first it's limp. First is you
painful.
cannot, yeah. But then you get that zaps.
The waking up sensation.
Yes. Imagine that now in extended version, they get that and you describe it to them. You tell them and they're not scared. And they see that actually as a positive sign. The nerve is not dead, it's waking up and so on. So half of the perioperative pain management we just covered.
Can I add
Yes,
to
please.
this? So, like you described, as the pain comes to the knee and then it goes slowly, it's going down. what we say, what I say, tell my patients, look, it's going out. It's going down.
It's going out.
The toe will be gone
Look,
away.
I'm going to use that. It's going to jump out of
Yeah.
the toes out.
It's like a positive reinforcement.
Yeah.
Mentally, they
Love
said, yeah,
that.
doctor's right. You know, it's getting out, down, and just
It's going to
it'll be
walk.
gone.
It's going to escape your body. I
In
love
fact,
that.
doctor, sometimes even if, they're
I'm
living
going
with
to
it,
use that.
sometimes even if they're living with it, they don't complain about
Yeah,
it.
yeah,
They
yeah,
think
yeah.
it's gone, no, I'm
Yeah,
fine.
yeah.
Mhm.
No, I'm going to use that. It's going to escape your body.
I think that's a fabulous point, even so Dominic and I do a lot of post-op. Our post-op periods are, we see them 1 month post-op, 3 months, 6 and 12. So a lot of that, we'll see them their 1 month post-op. They'll be frustrated with how slow it is.
Yes.
They're,
Mhm.
we watch them and we understand, we validate that this is frustrating.
Mhm.
Then we go and we see them at their 3 month post-op. And when I tell you, at least for me, it's night and day difference.
It is.
Now, to them, it's still
Mhm.
frustrating and
Yeah.
it's slow until you bring them back and you say, hey, remember 2 months ago when that foot was going like this and now they're flinging it around and
Yeah.
they're just concerned about the little numbness over the ankle. And sometimes it's just bringing the reality back to
And-
what it was.
And as well, telling them and making them understand, for them, the changes happen so slowly. The analogy I use is that when I see my children every day, I don't see them growing.
Mhm.
But when my sister comes, oh my God, you guys have grown, because you don't see. So the changes are so slow that you don't notice.
Mhm.
Who have seen these people in the painful period more than any of us is Tara, right there.
Okay, yep.
Tara, God bless her heart. She sees them, and I'm going to bring her up. Tara, any additional experience you want to share with anybody? So what do you see in this patient, 1 month, 2 weeks after the surgery, that is really memorable? And how do you manage that?
Yeah, so I guess just going along with what they say, I get a lot of those phone calls day 1, 2, 3, 4, 5, and so on about that. But yeah, I mean, we just reiterate what Dominic and Melissa really tell the patients, that it takes
So
time. It's gonna be
What do you
slow.
tell to the patient that call you and the first thing they call you, they're scared.
Mhm.
Some people
Anxious.
anxious, and some
Absolutely.
people specifically know what kind of medication they need,
Mhm.
right? And they're
Yes, yes.
allergic to anything but Dilaudid. It used to be Demerol. And Tara, God bless your heart, Tara, you filter them all for me.
Yeah.
So what kind of question do you ask them when they call, if they have pain?
Sure.
How does a typical conversation go?
Sure. I usually start with having them specify where their pain is. A lot of the times we can determine if it's more so, that nerve pain or if it's just normal post-op back pain. And then I just talk them through everything. A majority of the time, we don't necessarily need to transfer anything on to the APPs. We can just talk them through it. But yeah, I mean, they're all pretty similar.
Now, and you mentioned just flying by ADD, activity of daily living, correct? Did you
Mhm.
say activity of daily living? That is something that, we have to consider, that the activity of daily living, it cannot be the same as before the surgery.
Correct.
So we tell them no bending, twisting, lifting, and so on. So if they come and say, oh my God, I have 10 of 10 pain when I'm playing golf, maybe your body is telling you not to play golf. Expect managing the expectation regarding the activity is a huge part of what we have to do.
I have a quick point on that too, because I know Tara, she triages a lot of our phone calls. And the number one thing she does is patients definitely correlate any sort of pain with narcotics being the answer. Whereas I know she does a lot of education on narcotics do not help with nerve pain. It is a different receptor. However, they'll say, I'm doubling up on my pain meds. Nothing's taking away the pain.
So let's talk about it actually. What kind of pain do we have in perioperative time, and what works best for what kind of pain? So that goes a little to the physiology of the pain now.
Yeah, well, like I told you, we don't use narcotics, right?
Mhm.
So usually we use anti-inflammatories. And that there's-
Nociceptive pain.
Yes.
So in a surgical situation, you have a nociceptive pain. Dominic, what is a nociceptive pain?
Like it's right there. It's mechanical almost.
No, it is where the pain is originated. There are certain factors or I can show you all the diagram and so on, prostaglandin and so on and so forth, but there are two paths. They all come together, start a chain of cascade that activate our pain receptors. It is meaning the damage is being done. And let me be very clear. If you poke all those things tomorrow, we are going to poke in a person, your tissue will take notice of it. Okay? You cannot do our surgery and not have pain. Now, as a matter of fact, there's something that I tell all my patients. This is the fact. And many surgeons come and look at us and they go and try to replicate us. They see the tip of the iceberg, but they don't see all our protocols. But they copy their operative thing, but not our pain management and so on. And they call me horrified that the patient woke up in the worst pain of their life. They got a CAT scan, is nothing wrong and so on. What is going on? And my thing to them is, you saw some part, but you didn't see all the other things, I compare that to pain grade 1 versus pain grade 4 after burn. After grade 1 burn versus grade 4 burn. Alyssa, do you remember still what they are?
Yeah, we had kind of just had this conversation not too long. We always say grade 1 is like a sunburn, just kind of superficially. Grade 2 is when it gets into the epidermis. Grade 3 is when it gets down into the muscles, and 4 is like eschar, bone. Typically,
grade 4 you go to the burn to the bone.
Yep.
Now, what is the most painful burn?
2.
Yeah, grade 1. No,
grade 1 is even
grade
the most.
1.
I say
Yeah.
the lower you get, the less painful it is.
No, grade 4, the nerves that convey pain are dead. They're dead.
They cannot.
Grade 3,
It's
Yeah,
nice.
don't even-
those nerves are in epidermis.
Yes.
Grade 3, those nerves are gone. So the most painful, believe it or not, now grade 2 generally is more painful because always it's more surface.
Right.
But surface by surface, considering that, grade 1, the nerves are screaming something is wrong. Whereas grade 2, the nerves are almost numb. Oh my God, it's like they got beaten so bad, it is epidermis involved.
Yep.
And grade 3, the nerves are gone. Now, in a regular spine surgery, we open up, we burn the tissue, we burn the periosteum where most of those nerves are. And this patient, they wake up, all right. As a matter of fact, there is a method, we call that aquamantis. I see Dr. Gilmartin is with us. Dr. Gilmartin, do you know what aquamantis is?
Aquamantis is a instrument that we use in surgery when we are actually, instead of using a bovie, it does the work of bovie and cooling at the same time in the tissues. Is that what you're talking about, aquamantis?
Yeah, aquamantis is a bipolar anticoagulation to stop the bleeding, but it doesn't use like regular bipolar 35 volt or so. It uses like 120 volt, like electricity from your wall.
Is it a
It can go up to
flamethrower?
200 even.
Yeah.
Wow.
So when you're using it, it works really beautifully to stop the bleeding. When you're pulling it on the muscle, you see they turn into well done state,
Yep.
not even medium and so on. It stopped the bleeding. But do you have any recent information about what the rate of infection after aquamantis use? You're creating a
No,
lot of
no, I don't.
tissue.
Not that's the short
It's
is
about
the
10%, 10, 12%. So you need that. You don't, otherwise the patient will bleed and die.
Yeah.
Okay. Infection, we deal with that later. Okay. But when the bleeding is so much and so on, but it speed up the surgery because you don't have to stop this bleeding like ours. But that bleeding, you put the aquamantis, you pull it through, it kills all the tissue, it cooks them, literally cooks them. It smells actually like
Yeah, I bet
steak.
it does.
Yeah. But then at least patient doesn't bleed out and die on the surgery table, okay? If you do big surgery, it's a huge advantage. Now, but you should see, and those patients wake up pain-free. They have no pain. But then start infection. Pain goes for years, 9 months, 1.5 years, and so on and so forth. Whereas our patient, they have a rough first night. If we don't follow our protocol, and that's those surgeons I was talking about, they call me horrified. Why is patient in pain? The patient still go home next day because nociceptive pain. We poke holes in you. We put metal in you, and those are painful. Now, I'm going to talk about now we covered pre-operative pain management. Let's talk about patient hits the door. We go to the OR. We do the surgery. How do we manage the pain in the surgery? You guys pretty much know what we use there, right?
A lot of times we'll use topical agents even too, you know.
We
Lidocaine
use
is what
absolutely
we
topical
started.
agent.
Mhm.
We use a combination. We use a fast-acting like lidocaine and bupivacaine.
Mhm.
Lidocaine, we use it with epinephrine, so it stays in
Mm.
the tissue.
Yeah.
And we use 1% lidocaine with epinephrine
Mhm.
and mix it half-half with 0.25% bupivacaine without epinephrine.
Mhm.
We combine them and we literally put it where we are going to cut the skin.
Mhm. Mhm.
There's a limit of what you can give there, but that's a different conversation, especially lidocaine. Bupivacaine it's not as limited as lidocaine.
Hmm.
But why do we do this combination? More or less, we saw that historically it just worked better that way. But part of it is that lidocaine works right away
Mhm.
and as well construct the
Yeah.
vessels
Blood
with the
vessels.
with
Reduce
the
bleeding right there,
Yep.
you know.
yeah, and with the epinephrine, it constructs the vessel, it stays there, and bupivacaine gives you longer acting even after the surgery. So that's the first thing we do. In our surgery tomorrow, beside that bupivacaine, lidocaine, what else do we do?
For pain management, I
Yeah.
mean, we'll do Exparel.
Exparel, which is a liposomal lidocaine, meaning
Mm.
the lidocaine is in an envelope of fat. And because of that, your body cannot take it right away.
Yeah, it's
So
gotta
it
break
stays
down.
in the tissue and it takes like small little balls of lidocaine that in the next 2-3 days, it releases it and it
Mhm.
gives you additional nociceptive pain control, okay? Pain relief. Now, it's a very expensive medication. It used to be extremely expensive, still expensive. If you don't have that, in some of the hospitals, we give 0.75 Marcaine.
Yeah.
It's concentrated, so your body has more trouble dealing with that. It takes longer, but it doesn't act as long as Exparel, but it's better than nothing. And then we used to do epidural steroid injection. Again, inflammation. We want to reduce the inflammation. We used to do the epidural steroid injection that helps everything. Now these days, more or less, we put just Kenalog,
Mhm.
which is again particulate steroid, meaning it doesn't wash out like if you did Decathlon and so on. It just your body just take it, get rid of it. But Kenalog is a particulate, meaning your body little by little, you don't give them fluid, you give them a break of
Mhm.
small break of Kenalog,
Mm.
and your body breaks it down in the next 3-4 days. So over the next 3-4 days, it breaks it down, and then it has available for the nociceptive pain.
Mhm.
Now we just talked about the problem. You can whatever you give, like Kenalog, Exparel, and so on, 3-4 days. What do we tell our patient?
8, 4, 5. Those are going to be some of the worst.
Swelling is at maximum, and your body has gotten rid of that. So pain gets worse. There's a high level. Again, it's normal. It's part of healing. Nothing is wrong. Call us, but it's nothing wrong. It's just pain gets worse before it gets better.
And I think like that, you know, you're talking a lot about the medications we use, but I think there's even parts of the technique that are really nice for it. For example, let's say you're putting the rod in, making sure you are distinctly below the fascia is very important.
Oh, yeah,
there.
absolutely. Technique. I mean, how many times do you have to poke the hole? Now, you talked about something that's extremely important, but that is something surgeon has to take care of. That
Mhm.
if you put the rod above the fascia and lock the thing in and squeeze the fascia,
Hmm.
like bone, the most important painful part of the bone is periosteum. The most important painful part of muscle is the fascia. Try to manipulate it as little as you can. Okay, so this patient, and then we put the skin mix. We put Exparel or 0.75 Marcaine. We put a Kenalog in, either in the tissue or epidural, whatever your choice is. And at the same time, anesthesiology, you talk to them. What do? They can give acetaminophen or aspirin injectable, or they give ketamine. It's extremely important. Pain creates its own memory. Ketamine is not a pain medication, but in our brain
Mhm.
centrally dissociate the pain memory. Not only like literally patient have a lot of pain, but they don't remember, but it's an internal thing. Make sure you work with your anesthesiologist about that they know what to expect. And thank God we have a good anesthesiologist.
Yeah.
We talk about that and so on. So now patient leaves the OR. We are still perioperative pain management. So you have seen some of those patients that wake up in horrible pain. And this is one of those things. If you wait for the pain to be 8 and 10, sometimes it's hard to catch up with the pain. So what is our typical perioperative in the PACU and so on? And I'm going to share our screen here.
We sat down with, I think, a few different anesthesiologists or CRNAs to come up with this perioperative pain management
Correct.
to make sure that we had a lot of different options available. Because you'll notice that we have a 1, 2, 3, 4 system. However, we do not always have to utilize all of these. However, we do have the options available, which is really nice, especially for our staff.
So here you see our perioperative pain management protocol. You see, obviously, education is the number one.
Yeah.
And acetaminophen, we talked about that. That's anesthesiologists. Presidex works similar like ketamine, okay? And as well anesthesiologists. This is gabapentin can actually help. Even people who haven't been on gabapentin, and we are not talking about the high therapeutic dose of gabapentin. We are talking about something that smoothen the path for other medication to work better. Literally, what it does that's a very low dose, 300 milligram.
Yeah.
Extremely low dose. And then something long acting like OxyContin. And then obviously that's another thing that we recently established, the erector spinae injection. Do you guys know what that is? It is practically the paraspinal muscle along the spinal transverse process, that those are the erector spinae, that we inject with local anesthetic, and lots of pain in the spine is based on their action or inaction or spasm and so on. And once we put lots of metal in, we just know lots of nerves go along that tracks, and it seems to be very helpful. So, do you see what we say here? We don't want to sedate the patient before consent is done. That's part of our pain management protocol, okay? Now, if this doesn't obviously include the things that don't sedate the patient. So, intraoperative, we talked about the lumbar ESI or paraspinal muscle, skin, and then tordal. Now, let's talk about tordal. Many times, when we, after the surgery, when we talk about that, I say, give this around the clock. And then tordal is one of the things that we like to give around the clock, which is as well nociceptive pain, which is as well at the receptor level. And and we schedule it. We don't want to, for some reason, if you do in the hospital, especially in the hospital, something PRN, the nurses give narcotic, none of the other stuff. Okay? But we want them to be on certain things. We go over them around the clock. For the first 2 weeks, there will be on muscle relaxant and hydroxyzine. And I'm going to ask you, why muscle relaxant?
Well, I mean, they're all going to be swollen and inflamed.
You're poking to them, yeah.
Yeah.
And hydroxyzine, what is it?
Well, typically we use hydroxyzine as a counterpart with the narcotic for side effects of itchiness.
What is hydroxyzine?
Anti-anxiety.
It's anti-anxiety medication. But we know that, you remember that path in the brain, emotional response to the pain, a huge part of it is the anxiety, and the hydroxyzine really help with that. Visceral, or there's some other medication that
Can I just cut into this?
Please,
So,
please.
okay, I don't know whether you people use, but usually patients whom we take into the ER, we ask them what kind of music they like to listen to.
Oh.
And almost every time, whatever the kind of music they like is being played in the background.
Great idea.
We've
I
been
really
doing it
like
for
that
almost
idea
5
too.
years now.
Yeah. Now, Are those patients awake or are they
No,
sleeping?
all under general anesthesia.
They still work. It still
Yes,
works.
in fact,
Wow.
my anesthetists have now been insisting that every patient, as a protocol, we should know what kind of music they want to be
Wow,
listening.
that is amazing thing, and I have heard that before, but I have not met anybody who used that. But here we have somebody who used that with a positive result. Amanda will love that.
I even just the thought of, for example, this last Friday, I went in to see a patient in the pre-op room, and I walked in and their eyes were closed and they just had the Bible reading to them on their phone, and they just felt it was probably the most relaxed and at peace I've ever seen anybody before surgery.
Here you are.
And I
So
could
that's
see
work.
that, very well with music as well. That's a very
Yeah.
calming sensation, especially if, could you imagine being rolled into somewhere that it's like your choice of music, the song? Maybe that's just me,
Yeah.
but that would
No, no.
relax me
I
very
think you are
much
on
so.
something, and that is something that we should bring in. So, but let's move on because we have still a lot to cover. So it's still in the operating room, ketamine. Zofran surprisingly works to reduce your pain, and Decadron, we talked about that. They give it, usually they give it for laryngeal swelling, but we know it worked, but we as well put on top of that actually Kenalog in the tissue, which lasts longer. And methadone is again another long-acting. There's a problem with methadone. It stays in the tissue for a long time. So it's not my favorite, but for that reason is number 8. It's not number 1 and 2. Okay.
Last in the chamber.
Okay. Now post-operative. We talked about the Toradol, but we generally don't give it more than. You can give it up to 4 days, but we generally give it for 2 days. Now, initially, we just for the patient who go home, we don't give it, but I think we should make a habit for a 2 and 3 levels fusion. If the kidney function are all right, we should give it as well a prescription for them to take it home, a PO for 2 days.
Yeah, I think that's kind of good because a lot of the times the struggle with Toradol is that you have to do some of the first dosing either high when you're doing oral, or you have to get it intramuscular or IV first.
Yeah.
Continue.
And obviously, patient comes from the surgery, they still cannot swallow. Definitely something IV. This is something you probably frown upon, but this is routine here. Then they get always and some PO narcotic, and they go home with that. That is PRN. Now, it is based on, we have another protocol that shows progression. Now, if patient doing well, you go 1 step back. If patient is not doing well, you go 1 step forward. And then we have it multiple paths that, fast weaning, slow weaning. And so we have different method. I will show it that as well. And then obviously either Flexeril or Robaxin, very useful medication. And these days I have the feeling Robaxin works even better than Flexeril, but maybe that's just a bias. So, but either of them are fine. Visceral, we talked about the Visceral, which is a hydroxyzin.
Yep.
Correct.
I mean, they use it in ICUs for plenty of positive outcomes as well. It just kind of brings down that constant underlying anxiety and breaks the pathway up.
Now, Visceral comes in 2 different formulation. It depends on the site. No, not Visceral, hydroxyzin comes in 2 different formulation, depending on if it has a gluconate or different attachment ligand, we call that attached to it. It makes it heavier. So when you see Visceral 10 to 20% and then hydroxyzin 25 to 50, 25 to 50 is not the hydroxyzin anymore, the ligand. When they put gluconate, it makes it heavier. So you have to give more of it. Do a little research, look it up. There are 2 different formulations that 10 to 20 correlate to 25 to 50 of one versus another, depending on what kind of site molecule is attached to it, okay? But if you're going to use Visceral, it is usually, depending on the formulation, it's 25 to 50. Let's do a little more research on that, okay? Understand those things. Then obviously, then we have other pain modulators, we call them, that you can give. And then start long-acting physical therapy is extremely important. And few patients, we have to give ketamine in the PACU. But that is more anesthesia consultation, and they are there. They help us with that. And so I can tell you, probably 1 in 20 or 1 in 30 patient, the pain is so impregnated in their brain.
Mhm.
They wake up with screaming. No narcotic can help them.
Yeah.
And then you give them a little bit of a ketamine, they talk to you like a normal person. And then ketamine has a very short lifetime, short half-life. And then you see by the 8 minutes, ketamine is going down, they start screaming again, and then you dose it, and then they get better. Usually few doses is enough, but I have had a patient that needed to be on ketamine drip over the night. But that mostly doesn't happen in the ICU setting, okay? And obviously there are some, you see per anesthesia, there are some other things we can give. So now we discharge the patient. How do we discharge the patient? Now I want you, one of you, please go over that. You talk about it. What do we do?
Well, we will always start off with some sort of narcotic. Now, typically we start low and go slow. So if they're narcotic naive, we will always typically start them on the lowest dose, whether that's a Percocet or Vicodin 5 milligrams, and then we go from there. Of course, monitoring the acetaminophen dosage. Obviously, we typically start on a every 4 hours basis, asking them to take it as needed, staying on top of the pain primarily for that first week. You want to move to the muscle relaxer?
And then kind of like we mentioned earlier with the same thing with the muscle relaxers and the Visceral, we just keep those scheduled because a lot of the times patients have positive results while they're taking them, but they don't have the same social or cognitive bias that they do with a narcotic. They say narcotics can take away my pain. What is this muscle relaxer doing? And then they stop taking it for 2 weeks and suddenly everything hurts a lot worse.
So we are sending them home always with at least three
medications. Yep.
And we tell them, take the first 2, which is muscle relaxant and visceral around the clock, narcotic as needed.
Correct.
And now for 3 level, for sure, for 2 level, for selected patient, we are going to add Toradol, which is exactly the inflammation, and we poking you. If you are not prepared, it's a grade 1 burn, you will have pain. So, and that helps. So then, obviously, by the day 4 or 5, they call Tara, and then Tara probably adds some more go Flexeril or Robaxin, increase the dosage of that. And narcotic, always the last thing.
Yeah.
Okay?
Correct.
And if there's neuropathic pain that goes to the top of the left foot, then
Gabapentin or pregabalin or
yes,
first
gabapentin,
go-tos.
Lyrica, gabapentin. Gabapentin is my favorite, but there's a problem with gabapentin. You cannot go quickly up and down.
Oh, correct.
And you cannot just give it as needed. You have to go start, slowly go up, stay up, and then come back down slowly. Why?
Side effects.
What are they?
Man, I've heard a wide variety. Most of them are something in the head, whether it's
Most
brain fog,
likely-
dizzy.
Most likely orthostatic dysregulation.
Yep, there you go.
Okay. So when they're in the hospital, we start 300 3 times a day and go one day, then next day they're getting blood pressure checked and on monitor and so on. We can go 300 TID, then 600 TID. The maximum I use is 900 TID, but you can easily go to 1200 TID. Okay, that is considered high dose, but regular dose for the gabapentin to work is 900 TID. So if somebody comes, oh, I'm taking 300 TID, it's not working. No, I'm taking 300 in the morning, 300 in the evening, just before I get when I need it. That's not how it works.
Correct.
So correct that first, okay? And then once you are at the highest dose, when you're outside of the hospital, my preference is 300 just once a day. Second day, 300 twice a day. Then 300 3 times a day for 2 days or even 3 days. Then you go to 600 2 to 3 days, and then you go to 900 and stay at that. And you come back down as well the same way, because we don't want them to fall and crack their head at home.
Correct.
Okay.
And I think Tara does a lot of that education, kind of have a standing order. Same way we always tell people to take the first dose primarily at night, about a couple hours before they go to bed, so that they know if they have any side effects or symptoms without having to operate machinery.
And for people who have been on narcotic for a long time, and we know we have to put them on a high dose, obviously we send them home with a Narcan pen.
Yeah.
Are you guys familiar with it?
Yeah, the intranasal Levitt.
There's a
Yeah.
two-way version of it. One is the injection pen. The other one is the to just
Nasal,
put in the
I think
nasal and
is-
so on, and you educate them. That if you're not familiar with the risk score, go to internet. Just
Mhm.
you put their medication in and
Yeah,
some
it's
question answer, and
simple.
it gives you a score.
I say this, luckily the state of Minnesota kind of calculates that for us pretty
Mhm.
easily in the
Yeah, it's on the
PMP.
webpage
Yep.
again. Yeah. So and then this is just our perioperative pain management.
And then even
nerve-
steroids has a role there too.
If the pain is radicular and it doesn't get with other thing better, we do epidural steroid injection, we do nerve root injection and so on, which can be very, very, they come in horrible pain. You numb up the nerve, they come numb in that area, but then pain goes away and they're very happy about that.
Mhm.
That's for selected people because when you put the needle in, you may as well nick that nerve. That nerve is already angry.
Yeah.
It won't look upon you favorably if you nick it. Okay, so
Yeah.
don't take that lightly. Okay, and optional we talked about and so on here, right here.
Mhm.
On ketamine, obviously, but you see that call MD. I think first you call MD, then you give ketamine. Is overall a safe medication. It doesn't have as much respiratory thing, effect and so on, but it has a short lifetime and
Yeah,
it
exactly.
can have severe kind of effect and so on. So it still should be a very judgment kind of call
Sure.
medication. Now, last thing I want to talk about today is I want it all to be in one page. So I'm going to delete that.
There you
So
go.
put it all in one page, okay?
While you do that, there is a kind of pain which comes around 4th or 5th day,
Mhm.
and one should be
Yes.
wary of the pain because of infection.
Mhm.
Yes,
It's
Infection
very
is
different kind
always-
of pain.
I have a question, not a question, more of a statement. If you want to kind of, we ask our patients to kind of avoid our blood thinners or our NSAIDs after surgery, which leads us to the question of a lot of the time we'll give Toradol and patients will call in and say, I want a refill on my Toradol. I want more Toradol. And while we understand the benefit and the risk, I said, maybe you can better explain why we typically don't consecutively repeat this, at least in the
Toradol
first 2 months.
Toradol specifically because of the kidney effect and
Mhm.
liver effect. For a long time, we believed that Toradol has a effect on the anticoagulation. That effect is not very big.
Okay.
So I have no problem giving my patient Toradol. Specifically in our surgeries, we don't open up the lamina. What is the danger of spine surgery? You open up the lamina. If it bleeds, the bleeding itself can cause pressure on the spinal
Correct.
cord and so on. That has huge consequences. Most of our surgery, if not all of it, is done extra canalicular, meaning our surgery is transcambin, is not in the canal.
Mhm.
We don't open up the lamina. If it bleeds in retroperitoneal space. And now 300 cc of blood in retroperitoneal space is nothing. 300 cc pushing on the spinal cord is
Gotcha.
an emergency surgery.
Yeah, as a
Yes,
hematoma, you're
we
done
do.
in 4 hours. It's
Yeah.
over.
Yeah. So what I'm getting at is that, that is one of the advantages of our surgery. Our patient can be started on anticoagulation same day or next day if necessary, whereas regular spine surgery cannot. Now, Toradol doesn't have much of effect on that, so I'm
Okay.
very good with that. Now, other anticoagulation, we try to stop perioperatively, preferably for at least 48 hours.
Mhm.
Most of our patients are fine even next day.
Yeah.
Regular surgery, usually 5 days. That is at least used to be my preference for not start anticoagulation for 5 days after regular surgery, which it doesn't sound like much, but for somebody who has a valve,
Yeah.
artificial valve, is a lot. Now, talk about other pain medication like ibuprofen. For a long time, we thought it has an effect on fusion. Recent studies show that effect is not really hard, negligible. So you see Dr. Kim's old protocols, don't take ibuprofen for 6 months. No. I'm actually okay with that. If you want to be extraordinarily careful, maybe not the next 2 weeks while they are getting narcotic, but as soon as they're off narcotic, it would be all right to take ibuprofen or other non-steroidal.
I'm often faced with the question of, well, I don't want to take the narcotics. Can I just take ibuprofen? and we're saying a couple days or a couple weeks after surgery.
I think you know, again, I know that
Yeah, I was just coming to that. And we don't use narcotics, so
that's all you
and
can
we've
use.
got good rates of fusion.
Yes, here
Right,
you are.
which-
Here you are.
I typically am educate them based off of we say, we were taught that it could delay fusion, possibly, let them know, so
No,
they can make
we
an
can-
educated
We
guess.
can agree in 2025 that ibuprofen or other similar medication do not interfere
Okay,
in a regular basis with the fusion, and we have a proof of that right
I
here.
agree with you.
Yeah. So,
take it.
and last thing I want to show here is actually our weaning or progression diagram. You see,
Mhm.
we have the low, meaning that we quickly,
Start low and we get them off faster.
Yeah,
is typically
these are
our
people
route.
like young people, never been on narcotic.
Mhm.
Then on the outside, we have these people, we call them here high, that they take a long time to wean them off. And we have this for you to understand that if patient is doing better, go to the lower side. If patient is not doing better, go to the other side. And then based on your experience, you can say, okay, this patient, I need to move this patient from this group to this group, use it in a different way. So it's really just a visual thing. You, in your guts, you know what to do.
Right.
But this is just a visual representation that if the patient is doing better, reduce it. Sometimes they have the same level of pain, but with less medication and with more activity.
Mhm.
So the number of the pain shouldn't really make the decision, but the overall picture should make a decision.
Mhm.
Same thing when you are in the hospital, you look at the patient, that number they give you, I want you to put it on the bottom of their priority list. You look at the patient, you examine the patient. Patient is awake, alert, oriented times 3, making eye contact, speaking in full sentences.
Yeah.
You give him additional dose, you wait. How long do you wait? At least half an hour, preferably an hour. In that time frame, patient is going to call and drive everybody crazy. But I'm telling you, I have never seen a patient dying of pain. But I have seen patient dying of having 15 of 10 pain. Nurse gives another dose. 5 minutes later, I'm still in pain, give another dose. And top it off with an IV. So you give PO, IV, all of it hit the patient at the same time. And then you're surprised, patient quit breathing.
Yeah. So
Yes.
what we use here is when the patient keeps coming back to you, the no relief. Usually we also ask the family members. What do you think? I mean, how she's been or he's been doing in the last 2 weeks, and they spill the beans most of the time.
Yeah.
So because they come back for something very specific, and the family members help a lot. And the other thing which we've used is of late is the peer group. So we have patients coming back, say 3 months, 6 months down the surgery, and those which are in the first month of follow. They get to meet each other, and they probably help. Look, this is okay. It happened to me. Now I'm good. So it's like a positive reinforcement.
Well, I like your dynamic there. We have something else in the United States that is just the opposite of that. Patient and the family, especially, daughter, son, spouse, they have a dynamic. The family is so concerned about patient's pain and push the nurses and so on and drives everybody. And patient sees the family, if she's or she's that concerned, maybe I should be concerned. They aggravate each other up and up and up. Unfortunately, there have been few times that I had to ask the family, patient needs right now peace of mind and rest. Please, you go and take care of yourself. We take care of the patient. This is a huge dynamic that we have to work, especially when it becomes dangerous. Family knows exactly how you should manage. It literally hijacks the pain management from a specialist to a family who's emotionally involved in that.
To share another anecdote, actually, there was a patient who was in the hospital, and I remember I was on the phone at 9 at night yelling at the people who were managing her care because the mother was in the hallway badgering the nurses to give pain medication. And then she's blood pressure 60 over nothing.
Yeah.
And she's stated barely responding to any commands. And I'm like, what have you done to my patient? What is this?
So you remember that? They give pain medication, PO,
Mhm.
not enough. Give another dose. They don't wait enough. Another one. And worst of them all, the third one is IV.
Mm-hmm.
So it starts getting absorbed. All three of them hit you at the same time. And that's when you are talking about now, what is the safe way of dealing with that? You give a patient, you examine the patient. Patient is awake, alert, oriented times 3, making eye contact. I cannot overemphasize how important it is. And then talking in full sentences. At that point, you're safe to give another dose, but then you wait. What are you giving? What is the absorption? We know all those things. What is the absorption characteristic for that? At least 30 minutes. My preference is 45 to 60 minutes, because at that point, most of the medication is there. At that point, you examine the patient. Patient is awake, alert, oriented times 3, looking at you, eye contact, full sentences. You give another dose and you wait again. The worst thing is that now, let me tell you what happens sometimes. The nurse call you 5 times, already have given maximum dose, cannot take the patient's complaint anymore, call you, and when you tell them, no, wait, it is pain for PRN for pain, not PRN for nurse's comfort.
Yeah.
Okay? Then they report you. They report you 5 times here. That's the new thing here. Next time they call you, you hate to be reported. You
Yeah.
give in.
Just
You give in. And then before you know, they're resuscitating your patient, and patient is brain dead in the ICU. That is sometimes happen. And then sometimes what happens is that the nurse, they know who they call to get the prescription.
Yeah.
They know Abbasi is not going to comply. And we don't want to hear him. We call another. We have a young resident or young something. Oh, call him and so on. And then
That was exactly what happened in that anecdote I gave. They
No.
didn't call me. They called the hospitalist because I said no the time before. And then they called me when things went wrong.
so do you see that there?
Yeah.
You see the pattern there? So and so what that means is that we want to take pain seriously. Now, I guarantee you have been reported because you have said no to that nurses and so on, but that patient lives. So take a badge of pride, okay, that you did the right thing, the safe thing, and so on. You didn't, you didn't get the badgered into do something that is not safe and so on. So, but we have covered everything we want to cover. Any other comment or anything else? Okay, I think thank you very much.
Yeah.
Okay.
And thank you very much for providing your perspective, by the way.
Thank
This
you.
was fantastic to have that view.
Thank you.
So, well, for Essence, I'm Dr. Abbasi, our special guest,
Yeah, I'm Dr. Praveen Saxena.
I'm Melissa Hopper.
Dominic Moore.
and we have online Dr. Gilmartin and Tara. Thank you, all of you. Thank you. Bye-bye.